Thank you very much to the IPC for asking me to present this work. My name's Amaani Hussain. I'm an MRC clinical research fellow in Newcastle, and I'm presenting some of my PhD work, which looks at the use of artificial intelligence to predict biologic treatment outcomes in psoriasis. So as we're all aware here, biologics have revolutionized the treatment of severe psoriasis. And in the UK, we now have 12 licensed therapies. Despite the fact that these are highly effective drugs, still 25% of patients fail on their first biologic within the first year of treatment. And this increases to about 50% by the third year. And as clinicians, we have a responsibility to carry out cost-effective treatment decisions, but we have a real lack of evidence-based guidance to help us select the most safe and effective biologic on an individual level. So the aim of my work was to develop an explainable AI model that could help us predict the probability of continuation of the first initial biologic therapy. And this was using real-world data taken from BADBIR, which is our UK and Ireland psoriasis registry. This now has over 23,000 patients registered and over 16,000 in the biologics cohort. And it's data collected from over 165 centres across the UK and Ireland, so it's really representative of the real-world psoriasis population that we have. So we involved patients that were recruited to BADBIR that were adults with chronic plaque psoriasis starting on their initial biologic therapy. And we split this cohort into 3 different groups. The first group consisted of 80% of patients that we used to train a series of models, which I'll touch on in a second. 10% of patients were used to internally validate and optimize the performance of each of these models. And then a final 10% were used to evaluate the overall performance. So we used baseline patient data, so prior to initiation of biologic therapy, to train a variety of models. Firstly, a statistical approach, a Cox proportional hazards model, 2 types of machine learning survival models known as a random survival forest and a gradient boost survival, and then finally a type of deep learning survival model known as DeepSurv, which is much more complex in structure and relies on what's known as a neural network. So we found that the gradient boost survival analysis model outperformed the others, and we used 2 key metrics to determine the performance of each of these models. The first was the concordance index, or the C index, and that looks at how well the model does in ranking individuals on their risk of discontinuing therapy. And the higher the metric, the better it is at determining this risk, and ours was at 0.63. We then used a metric known as BADBIR score, which looks at how accurate the model is in its probabilistic predictions at different time points. And for this metric, the lower the value, the more accurate it is. And as you can see, at the earlier time points, we have a much more accurate predictive ability than at the longer term time points. We were able to generate predicted drug survival curves shown here, and as you can see, guselkumab was our highest predicted drug survival in red, and in light blue, etanercept, in keeping with our knowledge of the biologics. We used an approach called SHAP to look at the explainability side and determine which features were most important in driving the performance of the model. And this is a SHAP plot on the right-hand side. And if the metric is red to the right, it's positively associated with discontinuing therapy. And what this plot shows is that not only drug features, but also patient-specific features such as sex and baseline PASI were really influential in determining performance. But also some features less well recognized in the literature, such as lack of full-time employment and platelet count, were also positively associated with discontinuing therapy. So in summary, here I've presented a novel and explainable AI approach to predicting continuation of initial biologic therapy in psoriasis patients, and this is using our real-world data taken from BADBIR. This advances on previous machine learning and statistical approaches by being able to predict on both a patient-specific and a drug-specific level. I've shown through the SHAP work I showed before that not only drug features, but also patient-specific features are important in driving the performance of the model. And there's further exploration from the work that I've shown there for the future. So thank you very much for listening. Thank you again for the invitation, and to my supervisors and the BADBIR teams for that data. Thank you.
Thank you. Weight seemed to come out as well. Weight, so
yeah.
It was a...
Yeah, so weight, BMI, and also waist circumference were positively associated with discontinuing therapy, which again
is also very much linked to blood concentrations of biologics. We know from our research. Yeah, Catherine.
Lovely presentation. Lots of work. What's the next stage in terms of moving it into a clinically useful tool? What would you be doing, and what are you planning to do?
So I think the next stage would be externally validating it, so using a different data set. We're looking at using the SOBEST data set in Germany to externally validate it. And I know we've spoken before about potentially also validating it in a different disease as well, thinking about across other IMIDs. I think we need to externally validate it, certainly in psoriasis, looking at a different...
And I didn't quite get from the metrics whether this is likely to be, how clinically useful is it, in terms of the patient sitting in front of you?
Yeah, so I think it's better than where we're at now, where at the minute we're kind of choosing biologics based on contraindications and that discussion.
Is that 0.6? Is that the performance? Is that?
Yeah. So this is
correlate to a sort of
Yeah, so it's not quite an AUC kind of metric, but it's similar. And then further work that we've actually done has been trying to narrow the features that we actually train the models with, which has brought that up slightly. But I think the debate is, where could we really get to with clinical data alone in terms of performance, and, continuing to make this accessibly usable in the clinic without bringing in kind of genetics data and things like that, where that boundary lies. And I'm not sure where our performance will get to just exploring models further, but that's where we're at.
Curtin.
Interesting data. You had one peak there for current center.
Yes.
It was in a positive way. It's certain centers which change a lot, or if the patient stays within the same center, or what was that?
So that was the center that the patients were enrolled into BADBIR. So I think what it's shown is that clearly there's a difference between centers in discontinuation rates, and that is a potential predictor of outcome in some way. It's not really high up, but it seems to come in there. And I haven't looked into that kind of further, but I guess it represents our different demographics across centres. And as I said, this is kind of real world representative data, so there will be discrepancies there.
Perhaps I missed that information, but your outcome was discontinuation for any reason.
So this was either ineffectiveness or adverse events, and then the rest was censored, so other reasons were censored. But we've subsequently kind of split it, looking into ineffectiveness versus adverse events, but those are the two main reasons.
Very good. Thank you so much. Thank you.